Welcome to CardioCast for Friday, September 20th. I'm Dr. Jim Dwyer. This week, European cholesterol guidelines push targets below 55 milligrams per deciliter. Women may be able to effectively cut their heart failure drug doses in half, and angina after a myocardial infarction should set diagnostic gears in motion. But first, in surprising results from a landmark trial, Prasugrel proved superior to ticagrelor in acute coronary syndrome patients. Dr. Stephanie Schupke, a cardiologist at the German Heart Center in Munich, presented the results of ISAR-REACT 5 at the annual Congress of the European Society of Cardiology in Paris. In the trial of more than 4,000 patients with an acute coronary syndrome, with or without ST segment elevation, the one-year composite rate of death, myocardial infarction, or stroke occurred in 6.9% of those treated with Prasugrel and 9.3% of ticagrelor treated patients, for a highly significant difference of 36% favoring Prasugrel. And there was no difference in major bleeding. This outcome was totally unexpected. That's because even though both ticagrelor and Prasugrel enjoy a Class 1 recommendation for use in acute coronary syndromes in the ESC guidelines, it has been widely assumed, based on previous evidence, plus the fact that ticagrelor is the more potent platelet inhibitor, that ticagrelor is the superior drug in this setting. Dr. Schupke said it turns out, however, that those earlier studies were not germane to the issue directly addressed in ISAR-REACT 5, the first ever direct head-to-head comparison of the two potent P2Y12 inhibitors in the setting of ACS with a planned invasive strategy. New European Society of Cardiology guidelines set an LDL cholesterol target of less than 55 milligrams per deciliter for very high-risk people. It's a Class 1 recommendation, and it's the first time a cardiology society has either recommended an LDL target goal below 70 or endorsed treating patients to still lower cholesterol once their level was already under 70. The ESC released the guidelines during its annual Congress. But that's not all. The guidelines also suggest considering an LDL target of 40 in very high-risk secondary prevention patients who've already had at least 2 atherosclerotic cardiovascular disease events during the past 2 years. To reach those goals, the guidelines elevate the PCSK9 inhibitors to a top-tier Class 1 recommendation for secondary prevention in very high-risk patients who don't reach their LDL cholesterol goal on a maximally tolerated statin plus ezetimibe. That recommendation stands in contrast with the 2018 AHA-ACC guideline, which deemed the addition of a PCSK9 inhibitor only a Class 2 recommendation. For a complete rundown on the new ESC guidelines, click the link in the podcast notes. We'll be right back after this message. Women with heart failure with reduced ejection fraction may need only half the recommended doses of common drugs. That's according to findings from a new European study published in The Lancet. It concludes that men and women react differently to common drugs used to treat HFrEF, and women may be able to safely cut their doses in half and get the same level of relief as that provided by larger doses. Dr. Bernadette T. Santima of the University Medical Center Groningen, the Netherlands, and her co-investigators launched an ad hoc analysis of the findings of a prospective study of 1,700 HFrEF patients in 11 European countries who were treated with ACE inhibitors, angiotensin receptor blockers, and beta blockers. Patients were receiving suboptimal medication doses at the start of the study, and physicians were encouraged to increase their medication for nearly 2 years. In men, the lowest hazards of death or hospitalization for heart failure occurred at 100% of the recommended dose of ACE inhibitors or ARBs and beta blockers. but women showed about 30% lower risk at only 50% of the recommended doses. That was with no further decrease in risk at higher dose levels. And those sex differences were still present after adjustment for clinical covariates such as age and body surface area. In addition, women are much more likely than men to suffer side effects from medications, and the effects tend to be more severe, Dr. Santima wrote. She notes that current guidelines for use of the drug studied do not differentiate between the sexes, despite prior findings showing that with the same dose, the maximum plasma concentrations of ACE inhibitors, ARBs, and beta blockers were up to 2.5 times higher in women than in men. Angina should now be a red flag when you're following patients after a myocardial infarction. In a study of nearly 33,000 patients, those with angina who were also more than 3 months out from a prior MI had a significantly increased rate of subsequent cardiovascular death or non-fatal MI. Angina and prior MI should now be viewed as a higher risk subgroup that may warrant more intensive management, according to Dr. Emmanuel Sorbet of Avicenne Hospital in Bobigny, France. Dr. Sorbet presented the study results at the annual Congress of the European Society of Cardiology. Researchers reviewed data from patients in 45 countries with stable coronary artery disease enrolled in the Clarify registry. 60% of the patients had an MI more than 3 months prior to enrollment. In that subgroup, angina at baseline was linked with a 3.6% absolute increase in the rate of cardiovascular death or non-fatal MI during a median 5-year follow-up. That's compared with post-MI patients who did not have angina at baseline. That translates into a 44% relative increase that remains significant after adjustment for several demographic and clinical factors. Dr. Sanjay Sharma is professor of inherited cardiac diseases and sports cardiology at St. George's University in London. He says the angina finding should immediately influence practice.
Until now, the guidelines suggest that if someone with a chronic coronary syndrome has angina, we continue to add anti-anginal therapies, and if they continue to remain symptomatic, then they get revascularized again. The new message, of course, now is that if someone's had a prior myocardial infarction and they present with new onset of symptoms, I would see them as a patient that is semi-urgent, that requires urgent diagnostic workup with view to revascularization, and of course ongoing ongoing aggressive medical therapies. Anyone who's post-MI who gets new onset angina again is the patient that's highest risk and needs the most aggressive diagnostic intervention and, of course, urgent either surgical, angioplasty type therapy or pharmacological treatment.
You can find these stories and more by visiting www.mdedge.com/cardiology or by clicking the links in the podcast notes. This week's contributors include Randy Dotinga, Bruce Jansen, and Mitchell Zoller. And CardioCast, Cardiology News, and MDedge Cardiology are edited by Catherine Hackett. Remember, you can find CardioCast via Amazon Alexa, Apple Podcasts, Pandora, or wherever you listen to podcasts. And if you like what you hear, please leave us a rating or review. For MDedge, I'm Dr. Jim Dwyer.